I always have a hard time.
Well, we'll give everybody a few minutes just to go ahead and grab a seat. But good morning. Welcome to the 157th Landon Lecture on Public Affairs. The Landon Lectures were begun in 1966 by the late Governor Alf Landon and the late K-State President James McCain. The goal of the Landon Lectures is to bring the most prominent public figures to Kansas State University to discuss the pressing issues of the day. We are very pleased today to welcome Secretary of Health and Human Services Kathleen Sebelius to the Landon podium to join the 156 predecessors in bringing their thoughts and opinions on important public issues to the K-State community. We do have several distinguished guests in attendance, and I would like to ask you to hold your applause while I recognize these folks, and I'll ask you to stand, and once they're all standing, then we'll give a big round of applause. To begin with Lieutenant Governor Troy Finley, Chief of Staff Ray Ann Davis from the Governor's Office, Andy Tompkins, President and CEO of the Kansas Board of Regents, Dan Jordan, Secretary of Social and Rehabilitation Services for the state of Kansas, Regents Christine Downey-Schmidt, Mildred Edwards, and Dick Hedges, Representative Sidney Carlin, and Brigadier General David Peterson, Commander, Fort Riley. Folks, please welcome, help me welcome these folks. Thank you. While I get to stand up and give the introduction, there's really a lot of other folks that are responsible for making the whole day a success and to work on the invitations and so on. And I would like to introduce the chairs of the Landon Lecture Committee. Ed Seaton, Chairman of the Landon Patrons and Editor-in-Chief and Publisher of the Manhattan Mercury, and Dr. Jackie Hartman, Chairwoman of the Landon Lecture Series and Director of Community Relations for Kansas State University. Please join me in thanking them. We also have our campus leadership with us today. Dr. Betsy Cauble, President of the Faculty Senate and Department Head of Sociology, Anthropology, and Social Work, Becky Bonenblust, President of the Classified Senate, and Danny Unruh, K-State Student Body President and a Senior in Political Science. Thank you for being with us today. Today, I'm especially pleased to introduce Secretary Kathleen Sebelius. Since taking office in April of 2009, Secretary Sebelius has been a leader on some of President Obama's top priorities, including the implementation of the historic Affordable Care Act. She also has been working with Secretary of Agriculture Tom Vilsack on building a 21st century food safety system, which is an important area of emphasis and research at Kansas State University. As Secretary of Health and Human Services, Sebelius leads the principal agency charged with keeping Americans healthy, ensuring they receive the care they need, and providing children, families, and seniors with the essential human services they depend on. She also has been a leader during public health crises, coordinating the government response to the 2009 H1N1 virus and helping to provide rapid medical assistance following the oil spill in the Gulf of Mexico and the devastating earthquake in Haiti. Prior to becoming the nation's 21st Health and Human Services Secretary, Sebelius was twice elected governor of Kansas, serving from 2003 to 2009. The daughter of former Ohio Governor Jim Gilligan, she was the first daughter of an elected governor to serve as a governor in U.S. history. As governor, Sebelius led efforts to create jobs, improve access to health care, and improve education for Kansas children. Her accomplishments in the office earned her recognition from Time magazine as one of the nation's top 5 governors in 2005. Prior to her service as governor of Kansas, Sebelius was the first Democrat to be elected state insurance commissioner, serving in that capacity from 1995 to 2003. Her work earned praise from Governing Magazine, which named her the 2000 Public Official of the Year. Sebelius also served in the Kansas House of Representatives from 1987 to 1995. She has a Bachelor of Arts from Trinity Washington University and a Master of Public Administration from the University of Kansas. Please help me in welcoming Kathleen Sebelius to Kansas State University.
Well, good morning. Thank you. Thank you. Well, I want to start by thanking President Schultz for not only that nice introduction, but for your leadership of this incredible university. I didn't have a chance to really work with President Schultz. He was chosen as I was leaving Kansas, but I've certainly watched him in this capacity, and he's doing a terrific job. And K-State is not only important in the Manhattan community, it's one of the state's crown jewels, and I think it's a critically important university to our nation. And I'm really pleased to be here today also with lots of members of the Wildcat family, with the key members of the administration and faculty, with supporters, advisors, and students. And I'm also delighted to be here at the home of two of the nation's best coaches, Bill Snyder and Frank Martin. You know, Coach Snyder and I had a chance to work together on lots of issues as governor, most particularly on finding more adults to mentor Kansas kids. And he does a great job not only on the field, but each and every day in communities throughout this state. And I haven't had a chance to get to personally know Frank Martin, but I've certainly watched him and am one of his legions of fans. And I have to tell you, watching that Duke game the other night, a few more free throws and a little mojo for Jake Pullen, and K-State can beat any team in the country, no question about it. But what's really impressive about the coaches is they are both coaching kids for life skills and not just sports skills, and that's really what university coaching is all about. You know, I'm pleased to be back here with all of you. In my new position in Washington, I am really guided every day by the work we did here in Kansas to build a stronger, healthier, and more prosperous state every day of the year. It's great to be here in Manhattan. I have a real soft spot for Manhattan and for K-State. I married a Wildcat, which is what brought me to Kansas, so it will always be near and dear to my heart. And although I'm now on the East Coast, Manhattan to me always means Kansas and not New York. So I know this is a terrific place to get a college education, but also it's such an important engine for our state's economy, a steady source of innovations in so many areas from engineering to agriculture. And I'm especially proud of the work we did and that K-State was selected to be the site of a new state-of-the-art lab, one of only 3 in the world that will put our state at the forefront of animal health research, not only in the country, but throughout the global community. Now, our department, HHS, operates similar labs for human diseases through the Centers for Disease Control and through the National Institutes of Health. And I know how absolutely critical they are to the health and security of our nation. So I'm glad to see plans for this facility moving forward here in the heartland. And thank you so much for inviting me. As you can see, I still have an array of purple in my closet, and it's good to have a chance to wear it once again. But it's a huge honor to be invited here to give the Landon lecture, to be here where so many leaders have stood before in this great auditorium. And, of course, as President Schultz has already said, the first of those great leaders was Governor Alf Landon himself. Now, Governor Landon had a truly remarkable life. He was a great success in the oil business. He fought in the First World War. He served as governor of this state. He ran for president and eventually became one of our nation's greatest statesmen. Governor Landon was also fortunate enough to witness some amazing events in history. The invention of the automobile, the defeat of fascism, the civil rights and women's rights movements, technological leaps that put a man on the moon and gave us a personal computer. But I would argue that no area where our country has made more leaps during Governor Landon's lifetime than during the last century was our move forward in the health field. Governor Landon was born in 1887, and at that point, the average lifespan for an American was to live to mid-40s, which was only about a dozen years longer than the average lifespan of the hunter-gatherers who were on these plains thousands of years ago. But in 1987, when Governor Landon passed away just after his 100th birthday, the average lifespan of a U.S. citizen had risen to 75 years. That's a remarkable span. Diseases like smallpox and polio, which used to be every parent's greatest fear, were wiped out in this country. Conditions that had once been a death sentence became manageable. And the death rate for coronary heart disease had dropped more than 60% from World War II. The death rate for stroke was 70% lower than it was at the beginning of that century. And there are lots of reasons for those gains in health. Scientific breakthroughs like penicillin played a role. So did public health breakthroughs like improved sanitation and clean water. Public policy breakthroughs also helped, like Medicare, which provided unprecedented security for half of the seniors who, prior to 1965, had no health insurance at all. So those gains in health really transformed our country, because health is really about freedom. When we live longer, healthier lives, we've got more time to do our jobs, more time to volunteer in our neighborhoods, to play with our children, to watch our grandchildren grow up. But health is also the foundation of our national prosperity. Healthy adults are more productive workers. Healthy children are better students. Healthy families make greater contributions to their own communities. So when the health of a nation improves, we see the benefits each and every day in our lives. And today I want to talk about some of the steps I believe we can continue to take to make progress so that we can leave a healthier country for our children and our grandchildren. The most significant piece of health legislation passed in the last 45 years is the Affordable Care Act, which was signed into law last March. It lays the framework for reorganizing health care as well as reorganizing our health insurance system. Now, for years, we've had a health insurance market that was crumbling. Employers were dropping coverage, premiums were skyrocketing, consumers were getting more and more frustrated, and more Americans were shut out, priced out, or dropped out of the market altogether. Without health insurance or with insufficient health insurance, too many Americans went without critical care or saw their savings disappear in one accident or one family illness. And without legislation, the market would have continued to deteriorate over time. So over the last 8 months since the new law was signed, our department has been working closely with governors and lieutenant governors like Troy Finley, who's here today, insurance commissioners like Sandy Prager across the country, as well as healthcare providers and consumer groups and employers to implement the first parts of this new law. And while we've got a long way to go, we already see signs of progress right here in Kansas. So in the last 8 months, we've begun addressing one of the really unacceptable gaps in health insurance system, the so-called donut hole for seniors for prescription drug coverage. About 19,000 seniors in Kansas have already gotten some help with that drug coverage with a $250 check mailed this year. And next year, they'll begin to see a 50% decrease in the price of those prescription drugs. Eventually, that donut hole will be closed altogether. We've also established an early retiree reinsurance program that helps employers maintain health coverage for their early retirees. Now, right now, a lot of folks who retired aren't yet eligible for Medicare. They're not 65 yet, and they rely on their former employers for insurance coverage. But as health care costs rose, more and more employers ended that retiree coverage, which leaves folks in their early 60s with nowhere to go. And individual coverage for a 60-something can be very, very expensive. And so far, 34 major Kansas employers and unions, from Spirit Aerosystems to Sprint Nextel, have applied to be part of the program to keep their retiree coverage in place, and that helps stabilize a very fragile part of our market. And with support from our department, Kansas has also set up a pre-existing condition insurance plan where adults who had been shut out of the health insurance market because of pre-existing health conditions can now get affordable coverage on their way to 2014. One Kansan who wrote me recently was typical. He and his wife ran a business in Salina, and they bought health insurance year in, year out for their employees because they thought it was the right thing to do, and they wanted to keep the best employees in place. Then when they retired, they applied for individual coverage from the same company they'd been purchasing employee coverage from over the years. But because they had minor health conditions, they were denied coverage. And they wrote to me and said, we're worried we won't be able to find insurance coverage at all. But thanks to the Affordable Care Act, there are new options now for retirees like this couple. We've created a new patient bill of rights that establishes some long overdue consumer protections in the health insurance market, some new rules about areas that I saw year in and year out working as insurance commissioner. For example, insurance companies can no longer take away someone's insurance when they get sick just because of an unintentional mistake in their paperwork. And last week, we announced some new rules that companies will have to make sure that at least 80 cents of every premium dollar collected will be spent on health care and quality care issues, not on salaries and marketing and administrative costs. And there's one reform that's particularly important to students here today. Now, we know that young adults in their 20s have had very low rates of health insurance, being twice as likely to be uninsured as older Americans. Part of the reason is because it's not always easy to get a job that offers health insurance right out of high school or college. I know that because when our sons graduated from college, neither had a job with health insurance benefits. Our older son was going back to graduate school. We're not quite sure what our younger son was doing, but let's just say it didn't come with health insurance. But as part of the new law, young Americans who don't have insurance from their employers can stay on their parents' plans until their 26th birthday. So whether you're still looking for a job after graduation or going off to graduate school or working for a small business or a not-for-profit that doesn't offer health insurance, you won't have to worry about health coverage. Now, these reforms are not going to fix every problem in our health insurance system overnight. In fact, because we didn't want to disrupt the coverage that 180 million Americans already have, many of the important changes are phased in over time and don't take effect until 2014. But we're starting to fill some of the biggest gaps and end some of the worst abuses and give more control to all the people who felt like there was nothing they could do when their premiums went up 30% or their claims were denied. And as we go forward, I can tell you we're looking forward to working with all of our state partners to implement the law effectively and improve it along the way. But contrary to the impression you might have from watching cable news, there's a lot more to health than health insurance, and a lot more progress being made today than just the focus on the new law. So what I'd really like to do this morning is share with you 6 additional areas, reforms, investments, and technologies that I believe are essential to creating a healthier country. Now, this list is not comprehensive. It's not all we're doing at HHS, but they help to provide some of the useful examples of the kind of work that we can do together to keep America on track toward a healthier future. And along the way, they might answer another question some of you might have, which is exactly what does the Department of Health and Human Services do? So let me start with medical countermeasures. Now, here in Kansas, we do have a proud military tradition, and there's no doubt that a strong military is still the foundation of our national defense. But increasingly, the range of dangers we face is widening to also include biological, chemical, nuclear, and radiological hazards. We don't know where the next public health crisis is going to come from. It could be, God forbid, a dirty bomb set off in a university lecture hall. It could be a natural occurring superbug that resists all treatments. It could be a biological weapon we've never seen before, assembled from the building blocks of life by a terrorist in a lab. In order to respond effectively when the crisis comes, we need to have in place what are called medical countermeasures. The vaccines, antivirals, diagnostics, and other drugs and equipment that often are our first and best defense against these threats. Now, it's the same kind of response that the new Animal Health Lab here in K-State will help to identify for animal crises, and we're responsible for it when it comes to human health. The problem right now is that there's little incentive for the big drug companies, for the pharma companies, to produce medical countermeasures for conditions like Ebola virus or exposure to non-medical radiation, even though in the event of an outbreak or a nuclear explosion, those countermeasures are absolutely critical. So it's up to our department, working with the federal government, to figure out strategies to produce stockpiles of these important antivirals. After September 11th, the U.S. government came up with a plan to make up for the shortfall. But we still aren't as nimble and flexible as we need to be. So over the last 2 years, we were charged by President Obama with conducting the first ever complete review of the operation to develop and produce medical countermeasures. And we've identified a couple of key areas where we can strengthen our countermeasure pipeline. For example, one that we're exploring, which is actually used right now in the defense community, is launching a nonprofit venture capital firm, providing strategic support to the small companies that have big ideas but can run out of capital before they get that product to the market. The Defense Department has used this strategy very effectively in some new weapons development. Again, not something that there's a big market for, but an important issue. Another area is providing additional resources to the Food and Drug Administration, one of our agencies, and the National Institute of Health, another agency, making it easier for companies to produce countermeasures and navigate the regulatory system by creating clear regulatory pathways, analyzing promising new discoveries on a much faster pace, and helping identify and solve the scientific problems as they occur. The goal is getting great ideas from the microscope to the marketplace in a much more timely and efficient manner. And as all the athletes here know, how well you perform in the spotlight depends on how well you practice when no one's watching. So the same is true with our response to public health crises. How well we prepare now will determine how successfully we can respond when the next crisis comes. And we know, unfortunately, that we will have a future crisis. So the review gives us a roadmap for improving our preparedness, and we're working now with Congress to fill those gaps, and we need to follow that roadmap to a safer and more secure future. Cancer is another big challenge on our horizon. We need to provide some additional focus on this dread disease. One of the changes that we've seen since the days when Governor Landon was born is that we have to worry about new health threats. Many cancers don't become deadly until after someone's 60th birthday, so it wasn't a big issue 100 years ago when the average lifespan was shorter than that. But now what we see is more and more people, and half the men and a third of the women in the United States will develop cancer in their lifetime. That's a lot of our population. And the good news is that as cancer is becoming a more frequently seen disease, breakthroughs in science are giving us better weapons for fighting those cancers. For years, the main approach to treating cancer was similar, as the scientists tell me, to carpet bombing, where you attacked with radiation or chemotherapy all of the dangerous cancer cells, but you also killed a lot of good cells along with it, and you just hoped you weren't, on balance, killing more good cells than the bad. But thanks to the progress scientists have made cracking the genetic code, we now have the possibility of developing more effective targeted therapies. For example, We've got a new drug that NIH is testing right now, Herceptin, that can cut the risk of early breast cancer recurrence in half for patients whose tumors have a certain genetic marker, and it shows incredible signs of promise. But to speed the development of the new treatments, we've created what we call a cancer genome atlas at the National Institutes of Health. It uses funds from the Recovery Act, and we're expanding a comprehensive database of the DNA changes associated with 20 major tumor types. It would unleash a new generation of cancer treatments targeted at an individual's specific tumor. And we've just begun to travel down these research avenues, but we need to keep pushing forward. So the continued investment in that scientific research is so essential. Just since I began the speech this morning, 20 more Americans have died of cancer. And if we can speed up the development of the next generation of targeted therapies, we could strike a huge blow against a disease that now kills more Americans than any other disease beyond heart disease. To be a healthier country, we need new cures and treatments, that's for sure. So we've talked about countermeasures and we've talked about cancer. But we also absolutely have to improve the way we deliver health care. For example, every year, tens of thousands of Americans die from what are referred to as healthcare-associated infections, more than die from homicides and car accidents combined. Now, these are the infections that don't take you to the hospital. These are the infections that kill or injure you once you are in the hospital. And they're one of the top 10 killers of Americans today. Doctors at Johns Hopkins have developed an incredibly effective tool for saving lives in hospitals and in nursing homes and in healthcare centers. It doesn't take a huge investment of new equipment. It doesn't take new training. It doesn't take new personnel. It's really a checklist of protocols and procedures that have to be followed in every room, every time, by every provider. Basic steps like washing hands with soap and wearing a sterile mask, doing it each and every time in contact with patients. Now, it's hard to imagine that such a simple procedure could make a big difference, but when it was tested in Michigan hospitals and used by doctors who insert catheters into a major vein, the results were incredible. In 18 months, infection rates were down 66%, 1,500 lives were saved, and costs went down by $200 million, just with a small group of hospitals. And so if you hear those numbers, you must think that every operating room now in America uses a checklist, but unfortunately, that's not the case. The truth is that innovations travel way too slowly in our healthcare system. Recent research shows that it takes 17 years, that's 17 years, from the discovery of an effective treatment or protocol to be incorporated into routine patient care. By comparison, for many of you today, it takes seconds for your friends in California to learn on Facebook that you're in a new relationship or that it's complicated. But it can take years for a hospital in California to learn how a hospital in Kansas is improving care. So one of the best ways we can become a healthier country is to speed up the rate in which life-saving innovations and treatments like the checklist are adopted universally. And it starts with creating incentives that actually reward better care. So if you look at the new healthcare law, you see that there's provision after provision that create incentives for doctors and hospitals to deliver higher quality care and actually be reimbursed for that care. And to understand the potential of those changes, just think about the Michigan example. One quality measure, one kind of procedure, save 1,500 lives in 18 months, and multiply that by 50 states for just that one procedure. We know that we can do a better job delivering health care, and we can start to see the difference that these changes can make. Another area where the health industry is frankly way behind other industries in America is using technology. Another step that is going to help us dramatically improve the quality of health care is adopting electronic medical records for all hospitals and all doctors. Now, in industry after industry, we've seen the power of technology bring down costs and improve the customer experience. Imagine going back to the days where you were at a grocery store and somebody was hand adding all the handwritten price tags, or waiting for a bank to open so you could cash your check and actually have cash for the day. We cannot imagine those systems going backwards, but healthcare is different, and it shouldn't be. In fact, we've already seen the power of electronic health records across the country, cutting healthcare costs, reducing paperwork, improving outcomes, and giving patients actually more access to their own health information. 4 months ago, I was in Cincinnati, and I visited the neonatal ward of Cincinnati Children's Hospital. It does some of the most complicated procedures in the country on these tiny infants. They'd gone 1,000 days without a serious safety incident, a record they directly credited to electronic health records, because every provider in touch with every baby had to code in the medicine, code in the procedure. It was checked on a regular basis, and actually they were denied access if they were put in the wrong code at the wrong time. A big part of my job now is traveling around the country talking to doctors and nurses, and I haven't met a single healthcare provider who uses a high-quality electronic health record and said, boy, I wish I could go back to the days where we had those great paper files. It's really, the best way to practice. And yet, here's where we are in this country. 2 in 10 doctors and 1 in 10 hospitals even use a basic electronic medical system today. How many of you gone to the school clinic or to your doctor's office and handed the infamous clipboard where you once again record all of your health data, which somebody has on file somewhere, but it's not been transferred? And there's some reasons for this. It's not easy to learn a new technology, especially if you're a doctor in a small practice that doesn't have an IT department. And sometimes, if you're a doctor in a small practice and you're somewhere in rural Kansas, you are the IT department. So there's a challenge of being able to share information with other providers securely, even if they have a different system. And if you can't get information from your patient's other doctors, electronic records lose a lot of their value. And there's the fact that these systems can be expensive, even if they pay off in the long run. So what's happened over the last 2 years is an unprecedented effort to remove some of those barriers, to move medicine into the technological age. We've created health IT regional extension centers across the country, modeled exactly after the agriculture extension centers, where there are teams ready to come and visit with small providers and small hospitals to be the boots on the ground, to provide the technological expertise. We know how effective that is when teams from the Farm Extension Service can come to a farmer's land, look at the seeds they're using, look at the dirt, figure out what's working and what's not. And we want to apply that same kind of hands-on technology to the medical field. The health IT centers actually provide that kind of hands-on support, and one of them is going to be located right down the road in Topeka. We're also providing grants to help states create a framework, a statewide framework for docs and hospitals to exchange information with full protections on patient privacy. The good news is here in Kansas, we had done a lot of work in this area, so we're well ahead of many states in the country and ready to go. We're providing bonus payments for hospitals and doctors to adopt electronic health records and helping them to use those record keepers for improving patient care. Now, together, these investments are going to knock down many of the obstacles standing in the way of building a 21st century healthcare system, using technology to improve results and lower costs, just like every other enterprise. The result is that doctors are going to have more time to spend with their patients, more tools to do their job of patient care, more ability to coordinate that patient care. And America actually has a great opportunity to be a world leader in one of the growing industries of the future, the technology of health information. We know, again, that health and wellness is important. It's an important building block. If we want a healthier country, we can't just focus on what happens in a doctor's office or when you get to the hospital. We also need to pay attention to the air we breathe and the food we eat and the lifestyles we live. Now, right now in America, we have an obesity epidemic. 2 in 3 adults in America and 1 in 3 of our children are overweight or obese. This isn't a fashion crisis. It is a very serious health crisis. Obesity brings with it a far higher risk of heart disease, of stroke, and certain cancers. And it's the biggest predictor of diabetes, which can have crippling effects throughout a life. And that's why the administration has launched a really broad agenda to help Americans make healthier choices, from the First Lady's Let's Move campaign to the investments we're making in some of the most promising community strategies for reducing obesity, like bringing supermarkets to food deserts. And for a farm economy like Kansas, linking local grocers to purchasers can not only improve health, but also help that economy in the first place. One of the biggest obstacles we know to eating healthier choices is knowing really what foods are the healthiest. Now, most people know that fresh fruits and vegetables are better than a cheeseburger and French fries. Might not taste better, but they are better for you. But it's hard to guess that a tuna melt from a fast food chain has more fat than a stick of butter if you would sit down and just eat that at your kitchen table. Or to pick out the healthy cereal from an array of 50 choices. While you could go to a food chain's website or try to read the tiny nutrition facts on the back of packages, most people don't have the time, and frankly, they don't have the interest. But we know that giving consumers some additional tools and some information about the foods they eat can be helpful. So part of the Affordable Care Act will have chain restaurants begin to display calories for the different offerings on their menu, so people actually get a chance to see what choices they're making. We're working with food manufacturers and grocers to put easy to read, easy to identify labeling on the front of packages. So when you go to the grocery store after a long day of studying or work, you actually can figure out much more easily what is the healthier option. The truth is that most folks really want to eat healthier diets. Maybe not in Aggieville at 3 a.m., but most of the time you want to eat a healthier diet. But the challenge is to make a healthy choice more convenient, more affordable, more easily accessible, and that's really what we're trying to do. And finally, I want to spend a minute just talking about food safety. At the same time we're working on keeping Americans healthier, we need to put a new focus on keeping our food safe, an area that, as President Schultz says, is one of the hallmarks here at Kansas State University. Every year, millions of Americans suffer from foodborne illness. Hundreds of thousands are hospitalized, and thousands of people die. And the way our food safety system works in America today doesn't make a lot of sense. Local health officials begin to see an uptick in people getting sick, and they might suspect a foodborne illness. They then notify our regional folks at the Center for Disease Control that something is going on, who then send investigators to try and pinpoint where the outbreak is, and eventually the Food and Drug Administration is notified. They investigate the source, and they begin to warn the country about the food of concern. Still, the Food and Drug Administration has no recall powers of its own. They can provide a warning, but they can't get the food mandatorily off shelves. That's a voluntary activity. In other words, we're still working backwards. We chase the outbreaks after they occur, and we're always scrambling to catch up with what's making people sick. Not only does it cause a lot of anxiety and confusion for consumers who are shopping and trying to figure out what's going on, it also causes major disruptions and economic losses for farmers and producers. Every time someone gets a tainted food product and people get sick, the entire industry suffers. In farm states like Kansas, we understand the importance of a safe and secure food supply better than anyone. And we've seen firsthand how producers can take a huge economic loss if folks are scared away from buying a product, even if there's no scientific evidence behind it. So the problem is that we've been monitoring a 21st century food system with 20th century tools. Today, nearly half of our fruit and over 3/4 of our seafood comes from overseas, whether it's tropical fruit from Mexico or Chilean sea bass that you enjoy in a restaurant. But many of the importers don't have the same strict food safety standards that we have here in the United States. And as the food system has evolved, our methods for monitoring what's being served in people's kitchens has not. The last significant food safety-related changes, the Food, Drug, and Cosmetic Act, took place in the late 30s, before many of the students' grandparents were born. And so one of the biggest challenges as Secretary of Health and Human Services has been working in close collaboration with Agriculture Secretary Tom Vilsack, a former governor from another farm state of Iowa, to build a 21st century food safety system. It's been a top priority of the president, and we want to move forward with a system where we can prevent outbreaks in the first place or catch them early, much closer to their source, and give people the information that they need at every step along the way. There's legislation pending right now in the United States Senate that would be the biggest update to the food safety efforts in decades, and we hope it will pass soon so that we can start reducing these preventable deaths. So I've just talked about 6 areas, steps we can take to become a healthier country: strengthening our medical countermeasures and pipeline, pursuing targeted therapies against cancer, reducing healthcare-associated infections, switching to electronic health records, putting better nutritional information in people's hands, and building a 21st century food safety system. Now, they're all top priorities for our work and areas where we're either currently making or plan to make significant progress. They're also goals that most Americans can support. Making sure we have an adequate supply of vaccine and antivirals for the next public health crisis isn't a Democratic strategy or Republican strategy. It's an American strategy. The new food safety bill has strong support from both parties. We can all get behind saving lives and lowering costs by reducing hospital errors. And yet you rarely hear about those stories in the newspaper. And that's not surprising. There'll always be more coverage of political battles than on areas where there's a lot of agreement. A plane crash that kills 200 people will always be a more dramatic story than a hospital checklist that saves 2,000 lives. But it's important that we don't lose sight of these opportunities, because it's these steps and steps like them that will determine whether we continue to make the same kind of gains in healthcare that we have made over the last century. We should never fall into the trap of becoming convinced that progress is guaranteed. Recently, there's some pretty dire news on the horizon. Experts have said that we are raising the first generation of American children in 200 years to have shorter lifespan than their parents. And after the enormous gains we've made in health during the last century, our momentum is in danger of slowing to a halt and even reversing. But it doesn't have to. If we work together in the areas we agree on, compromise in the areas we don't, and make health a top national priority, I'm confident that the students here today will be able to look back at the end of their lifetimes, as did Governor Landon at the end of his, and know that they're leaving their children and grandchildren a stronger, healthier, and more prosperous America. Thank you so much for having me here today. Thank you. Thank you. I've already told the president he gets the tough questions, so.
Well, it falls to me to moderate here for the next few minutes. So we have microphones on each side, and so if you have a question, we'd ask you to come down and ask at the microphone. After we have questions from the audience at large, then we'll sort of shut this part down, and the media will have a chance to meet with the Secretary for a few minutes after that. So what questions might we have? Yes, sir.
Hello, Secretary Sebelius.
Hi.
Hi. Welcome back to Kansas.
Thank you.
I'm one of the pediatricians here in town, and I enjoyed your presentation greatly, but you obviously avoided any talk about the health care bill that has been passed in March, other than your initial 6 points that you mentioned. So, in view of the election that just occurred and the feelings throughout the country of dissatisfaction with the health care bill, which seemed quite obvious, and the fact that not one Republican voted for the bill as it currently is written, do you feel the bill will be repealed, or do you feel it will be amended? And I couldn't agree with you more on your other 6 points about what you do in the Health and Human Services Department. But there obviously are problems with the bill as it is written, and if you could spend some time addressing that. One other question: how much of the bill does the Human Health and Services actually have input into the legislation when it was finally written? Did you personally interject a lot of the nature of the bill? And maybe you can go from there.
Sure. I think that I did try to cover some of the main features of the bill that are being implemented right away.
Most people would agree with those.
Well,
and any bill, but what else is in the bill needs to be addressed.
Sure. There are lots of features of the bill. I would say it's basically two parts, kind of the insurance market changes, which some of the immediate changes I addressed earlier, and builds over time to a new state-run health insurance exchange, which actually, again, has, I think, broad support when people understand what it is, to replace the parts of the market, particularly for individuals buying their own coverage and small business owners, where they can be in larger pools and have more competitive choices. A state-run program. And what we're doing right now is working with governors and insurance commissioners around the country to make determinations of whether or not they want to run those exchanges. The rest of the bill deals with a lot of the underlying health changes, more investments in workforce. As you know, we don't have enough primary care docs. We don't have enough pediatricians and gerontologists. So there's a major investment in the workforce. There's a major investment in community health centers, so they'll double in time over the course of the next 10 years. There are incentives in place so we can use the public payment system for Medicare and Medicaid to begin to make some of the changes that we've talked about. So I don't have any question that the bill is likely to be changed over time. I think the talk about repeal is one that the new Congress will decide. The votes are probably in the House of Representatives to pass a vote to repeal the bill. I don't think they're there in the Senate. I don't think the president would sign a bill that repeals the Health Care Act. So in the meantime, I think we'll work on making it better. Medicare, passed 45 years ago, doesn't look much like it did when it was originally passed. It set a platform, and I think there are going to be lots of areas that we can work on together. But most people who I talk to, once they listen to the features of the bill, want a lot of those improvements to go forward. So I think there'll be a robust debate. We've set a platform, and we'll continue to implement it. To your final question, how much input? There were 5 committees in Congress, 2 in the Senate and 3 in the House, who actually had drafting authority and wrote parts of the bill. But we were certainly very engaged and involved, and I can tell you we're front and center in the implementation. There are about 3,000 references in the bill to the Secretary shall ... and that happens to be me. So we are
an awful lot of references to the Secretary will do this, and I was amazed just looking through the bill how much power you will have in implementing the bill.
Well, we're working very closely with provider communities, with the AMA, with the Nurses Association, with the Hospital Association, and others to, get input as these initial regs are written, and we'll continue to do that. I mean, that's sure. Thank you.
Yes, ma'am.
Secretary Sebelius, I'm a psychologist practicing in the state of Kansas, And my question is about Medicare, and I'm aware of the nursing home lobby. I was wondering if you are planning any changes in the way Medicare is implemented so that more people are supported through Medicare for staying in their homes as opposed to a nursing home.
Well, actually, Medicare itself, as you know, does not have a long-term care component. Most people who end up on public assistance at the last days of their lives are Medicaid eligible, and that often is what pays for nursing home care. There is a major project underway, and actually we did a lot of work on it again here in Kansas, and that work is really expanding nationally, which is called The Money Follows the Person, where an effort is being made to build much more kind of continuum of care in communities. So that's one of the missing pieces. You can't really have folks stay in their home communities unless they have services available. Many people would much rather prefer to be independent for a lot longer period of time. Some need help with activities of daily living, or help making lunch, or to make sure that they are being cared for adequately, or they take their meds. So those programs are really being looked at, and a lot more resources are being shifted, particularly to states like Kansas, who has begun to build that continuum of care. Another piece of the Affordable Care Act is the so-called class legislation. And what class does is set up a voluntary employee checkoff where an employee over a 5-year period of time can build essentially a savings account of their own to then use for a whole variety of community care services. It's not a long-term care insurance policy. It really recognizes that a lot of people would like to have residential care, home health care, opportunities to stay in their own home. So that is part of the system we're looking at. But aging in place is one of the, I think, hallmarks of a lot of the legislation moving forward, because people would really prefer to do that. And the good news for Kansans is that Kathy Greenlee, who was the Secretary of Aging here in Kansas and worked in our administration, is now the Assistant Secretary for Aging in Washington. She brings that sense of, I think, community service with her, and has done a lot to begin to transform that agency, which is also under our office.
Thank you.
Sure.
Beth.
Secretary Sebelius, thank you for coming to give this very informative lecture. We're very proud to say you're a Kansan.
Thank you.
My question is in relation to the information technology, and with respect to the health information exchange movement. How is that progressing, and have experiments like those occurring in Michigan been successful?
Well, I think that a couple things have happened. For years we talked about electronic health records, and the problem was there was no national platform. And what a lot of people were reluctant to do is invest in major systems for electronic health records and not be sure if they were going to be able to talk to the hospital in the next town, or the pharmacist, or so that standards have now been set nationally. There are now products available that meet those standards, and that gives confidence to folks to begin to invest. And then this system of state networks and information exchanges, I think, is part of that framework to provide technical assistance and support. So we're really hoping that once the financial incentives are available, and they start in January of 2011, that we are going to see a major transformation where people, both doctors and hospitals, are going to not only have the confidence that they've got a system in place to exchange information, but the privacy standards are in place, and will begin to make the switch to electronic health records. No question that they can reduce error rates dramatically. No question that providers say, they can just deliver a lot better care if they can pull all the information about what tests their patient has received from other providers, what medications they're on. That information can be transferred safely and securely to providers. I think it's a a real opportunity for us to have far better care delivery in the very near future.
Yes.
Hi, I'm environmental graduate 2005, political science geography. My question is, with regards to the constitutionality, well, first I guess I would like you to talk about the requirements of someone that doesn't have health insurance, what they're going to be required to do in 2014, and then whether a constitutional amendment should be enacted to possibly make it more lawful, I guess. That's my question.
Well, in 2014, the assumption is that in order to have really a viable insurance market, you need everybody in. So if you get rid of the rules for insurance companies that say you can't any longer eliminate people because of their health conditions, we have to have a mechanism to make sure that healthy people as well as sick people buy insurance, or nobody would buy it until they get sick, and then you would have a totally unaffordable system. I think the best comparison probably is if you think about car insurance. If you were only buying car insurance once you had a wreck, you'd have a pretty unstable marketplace. You really need, people in the system. So the theory is that everybody has a responsibility. Employers who have 50 or more employees are going to be expected to provide insurance coverage for their employees, or they will pay into a pool, recognizing that those employees are often now getting taxpayer-supported insurance coverage, or their kids are, so kind of a pool that pays back the taxpayers. Medicare will be in place. Medicaid would be expanded to cover people up to 133% of poverty levels. And the final piece is, if you are an individual without a financial hardship exemption, you will have an opportunity to purchase affordable coverage in a larger pool. You'll have financial subsidies that will be available to you, but it's a joint responsibility notion that everybody comes into the pool, and coverage will be offered by private insurers in a state-run exchange system. There are challenges that are being brought about that piece of the insurance bill, whether or not it is constitutional to say that individuals must have health insurance. And the real issue is whether or not the Commerce Clause gives Congress that authority to affect issues that deal with insurance. There's a lawsuit in Virginia, one in Florida, one in Michigan. The only ruling so far has been a Michigan federal judge who said on the merits that he found the individual mandate to be constitutional. He said, yes, it is. The Virginia and the Florida judge have not yet ruled. They have had procedural motions, but those rulings are likely to come. And my guess is the case will work its way up into the Supreme Court, because this is a fairly novel point in law. And but the assumption is that if you have a functioning insurance market, you must have folks who are sick and need the coverage to pay for long-term illness, and people who are actually purchasing coverage who may be sick at some point in their lifetime. And in the meantime, what we have is taxpayers essentially footing that bill. If you have health insurance today, you're paying about $1,000 additional for your health insurance for the health care delivered to folks who don't have health care, because you pay more for hospitals, you pay more for your doctor visit, and you pay more as taxpayers for the system of support for folks who are coming through emergency room doors. About $56 billion a year in uncompensated care just in hospitals alone. So those costs are now being shifted into certain paying groups, and this would have a personal responsibility piece of that puzzle.
We are running short on time, so we're going to do one more question over here and one over here, and then we'll have to call it quits. So
okay.
Go ahead.
Thank you, Secretary, for coming today. I'd like to state, my opinion is that there will be some changes in the new plan as it goes through. But at the same time, I would like to commend you for putting something on the table, which I think needs to be on the table. I think that I serve on a committee of a board of directors of a corporation that has seen their premiums increase 49% in 2 years. That is cannot be sustained forever and ever, and it has hurt our employees. So what I would I serve as an ex-official on a hospital board that has seen charity given out every year of over $1.5 million in a rural area because they didn't have insurance. Under your plan, will that be taken away so that the hospitals will not be handling that type of cause?
Well, as you know, the federal law, well before the Affordable Care Act, mandates that hospitals really sort of accept all comers. So if someone shows up at the doors of a hospital and presents as an illness, you can't check their insurance at the door and say, no, you go down the street or sit on the sidewalk. So hospitals are currently, as you say, you see it in your hospitals, but that total is about $56 billion in uncompensated care. And what happens is that care isn't totally uncompensated. It really is being paid for by people who have insurance who are paying a share of that cost to keep those hospital doors open. So I think that the bill anticipates that there is finally going to be a payment system under everybody, and that no longer will we just be taking it from one group and shifting it to another, but there will be more of a personal responsibility piece. And I think in your example of the premium increases, what we know is there are also clearly underlying health increases along the way. But as those costs skyrocket, in your case 50% increase almost in 2 years, employers are choosing, particularly smaller employers, are dropping that coverage because they can't, it affects their bottom line, so they can't pay it. So we now have the highest number of uninsured, and some of this is clearly the economy, but 50 million Americans right now have no insurance coverage at all, the highest number that we've ever had in this country. So the cycle that you're explaining of higher costs, increased rates, increased hospital expenditures is likely to accelerate, because folks who drop coverage first are often young and healthy, and people who are older or sicker are in a situation where they are really frightened to drop coverage. So we get a smaller pool, but a more risk-selected pool, people who will use healthcare services even more.
Thank you.
Thank you. Last question.
Good morning, Secretary Sebelius, and thank you for coming back to Kansas. Good morning, President Schultz.
Hi.
I have a dual role in serving as the Executive Director for the Kansas African American Affairs Commission and also serving on our Kansas Board of Regents. So my question is, given the Healthcare Reform Act and some of the changes that have taken place that would allow us to leverage some of our resources in order to improve health status, I see a movement away from disparities and really understanding disparities as they are impacting our health care needs as well as our system. What will happen given the act with the Office of Minority Health and how that impact our focus on disparities? And secondly, we celebrate some of the things that are taking place in our Regent system with regard to preparing our students to become the professionals that are needed in the future to address some of the healthcare needs. What are some of the other things that you would recommend to the state of Kansas in our educational, post-secondary education system to be well prepared?
Well, first of all, thank you for your dual service. Both of those efforts are incredibly important. Not only the African American Commission, but the Board of Regents is a hugely important role. So thank you for doing both. The health disparity issue is one that I think we absolutely need to continue to focus on. There is a major gap in delivery of health services, in access to health services, and in, frankly, the kind of treatment you get when you access the healthcare system, depending on your race and ethnicity and economic status. And we're spending a good deal of time and energy looking at where those gaps are. First of all, trying to fill the access gap. So I mentioned the community health center size and the fact that there'll be more community health centers, which are not only in urban communities, but often in rural communities, places where folks do not have access to a primary care provider, and that gap needs to be filled. We're looking very carefully at what are the research issues that we can learn about of why there is such a disparity in adult males in diabetes rates, for instance, and spend more time and energy. It will help to have everyone with some insurance coverage, no doubt about it. That will make a major leap forward. But having insurance access doesn't necessarily guarantee health care access, or particularly health care access that is equal. So a lot of time and energy is being spent looking at the data that indicates what some of the barriers are. We know one of the barriers is workforce. Having a culturally competent workforce and having a workforce that is more diverse than the workforce of the current day is important. So there are also efforts to recruit more minority providers, to recruit providers who speak languages other than English, to make sure that healthcare delivery can connect with the communities that we're trying to reach, and that, I think, will continue. If you look at the economic data in this, what has been the worst economic downturn since the Great Depression, the one industry that continues to grow is healthcare. And so if your students are looking at the future, whether it's to be a direct care provider at any level, everything from certainly doctors and nurse practitioners and specialists to community health workers are being hired and trained in communities across the country, because we have an aging population and because we have a system that we're trying really to shift from a sick care system to a health care system focused on primary and preventive care in the first place. So the whole spectrum of health workers is going to grow. We talked about health technology. There are a huge number of great job possibilities in that area. And we have one of them, we have Cerner right here in the Kansas City area, which is one of the international leaders in health information technology. Before it was cool, they were talking about it. But if the United States actually engages in this electronic health record, that will be a growing area. And I think, the research possibilities that we talked about, certainly the research and science being done on everything from medical countermeasures to life-saving drugs is a huge growth area. As we've unlocked this human genome, the National Institutes of Health is now headed by Dr. Francis Collins, who won a Nobel Prize in Medicine for his work in mapping the human genome. He's the head of our research division, and the work that's going on for researchers in trying to unlock the possibilities of cures based on what we now know about DNA is extraordinary. So I'd say any number of those health areas, from basic technology, care workers, specialists, is going to be a growing area and an area in demand well into the future.
Thank you.
Well, folks, we appreciate everybody coming out today, and please join me in thanking once again Secretary Sebelius.
Thank you, sir.